Welcome to Chapter 31, entitled Pharmaceutical Care in Pediatrics. When providing pharmaceutical care to the pediatric population, pharmacists need to take extra care and be vigilant to try to prevent some of the common drug-related problems that have previously been reported too commonly for this cohort. Through the medication review process, see Chapter 6, pharmacists make recommendations on appropriate dose adjustments, intercept potentially harmful medication errors, determine patient adherence, identify drug-related problems, and take action where necessary, such as educating parents and children themselves. Considering that pediatric patients are more likely to experience adverse drug misadventures, they may need a narrower follow-up period than their adult counterparts, and pharmacists are able to apply advanced pharmaceutical and therapeutic knowledge to monitor for adverse, as well as positive outcomes. Some important general principles when treating children should be followed. 1. If the infant is very young, less than 3 to 6 months, then most often a referral would be appropriate. 2. If the child is very ill, lethargic, listless, and inconsolable, referral is required. 3. If a medication is to be given, then make sure the dose explained to the caregiver is correct. Many medicines will be dosed according to weight. 4. Show the caregiver how to effectively administer or use the medication, e.g., show them how to use a syringe for measuring liquid medications. 5. Involve the child, when old enough to take part, in their own care and encourage communication between the child and their parents, because at some stage the child will be responsible for their own medication use. Next we will look at an introduction. Pharmacists can assist caregivers to manage children's minor ailments or even children's chronic diseases through the provision of pharmaceutical care. The principles in providing pharmaceutical care in pediatrics are not so different to those that we apply to adults, although it must be noted that depending on the age of the child, pharmacist may be speaking and educating predominantly the caregiver. However, as children get older, it is recommended that they become involved in their own pharmaceutical care. In fact, research suggests that children perceive themselves as active participants in medication use and claim they are more autonomous than their parents perceive. This pinpoints the need to educate both children and their caregivers about rational medication use. It should be acknowledged that while pharmacists as healthcare professionals, abbreviated as HCPs, are at the forefront of promoting children's empowerment in medication use, parents should not be left out. Studies have illustrated that parents are not only influential in affecting their child's medication use and health outcomes, but also health-related orientation and expectations to use medication in the future. This is because children indirectly adopt their parents' perception, knowledge, and habits through daily interaction, a process also known as the socialization pathway. As shifting of primary responsibility of medication use from parents to children is unavoidable as part of the growing up processes, the USP has encouraged parents to empower children by involving them in and negotiating gradual transfer of responsibility in medicines used with their offspring. These are essential things to consider when thinking about providing pharmaceutical care to the pediatric population. This chapter uses pain and fever, colic, coughs, and colds in the minor ailments category, highlighting in these scenarios the important information to be disseminated to parents predominantly, as these are minor ailments often occurring frequently in very young children. In the chronic conditions space, eczema and asthma have been used as examples to highlight pharmaceutical care provision involving both children and parents as active partners. It must be noted that as well as the extra complexity of needing to provide information to both children and caregivers, the use of medicines in children has a number of additional challenges that may not exist in treating the adult population. Firstly, a child's age and size can affect the pharmacokinetics and dynamics of many medicines. This means that we often need to classify children according to age and size, and not just treat them as mini adults. Most doses in children also need to be calculated by weight, adding extra complexity. Errors in dosing either at the prescribing or the administration stage are also common. And finally, there are many medicines used in pediatrics that are used outside their approved guidelines. This is known as off-label prescribing. It is these complexities that make it essential for pharmacists to be extra vigilant when providing pharmaceutical care to the pediatric population. Next, we will discuss patient group definitions. The definition of a child can vary from reference to reference. Hence, cohorts of children that pharmacists provide services to under the umbrella of pediatrics can be from birth to 21 years of age, that is adulthood. However, for the purpose of this section, we will be focusing mainly on children from birth to 12 years of age, where the dosing of most medicines in this cohort are more specific and often extra steps in dose manipulations are required in these age groups. Neonates are classified as children from birth to 1 month of age. The neonatal period is a period where a vast amount of physiological change occurs. This means that there are some very specific doses of medicines given to babies in this period that take into account these rapid changes as well as the varying rates of gastric emptying, the extent of drug absorption, and renal and hepatic clearance of drugs. As neonates are a specific category of children that should be under specialist medical care if requiring medicines, treatment of this age group is outside the scope of this book. Infants are defined as children from 1 month to 2 years. Young children are considered from 2 to 6 years, and a child is defined as being from 6 to 12 years. This section of this book will be covering medicine administration predominantly for common minor ailments, as well as looking at asthma as an example of a common chronic condition for children in these age categories. And now we will progress to dose considerations. The majority of doses in pediatrics will be calculated based on the child's weight. That is, they will be dosed by multiplying the child's weight by the recommended number of milligrams for a particular medicine. For example, paracetamol's standard dose for a child under 12 years is 15 milligrams per kilogram per dose. However, in children that have a significantly different weight to their ideal body weight, for example in an obese child, there will be times that the dose will be calculated on ideal body weight based usually on the medicine's ability to disperse into adipose tissue. Therefore, in an obese child, extra dosing considerations need to be made to calculate the dose based on ideal body weight for height. Dosing errors are unfortunately far too common in children and often occur at the time of prescribing or at the time of dose administration. Due to the increased need for dose calculations, dilution, and manipulation of medicines, a substantial proportion of preventable dose errors are reported to be 10 and 100-fold errors. Dose errors, however, also extend into the home environment, where research has revealed that the majority of caregivers, when asked to state and measure a dose of paracetamol for their child, will administer an inaccurate dose for the child's weight. Other research has shown that parents often choose a household spoon rather than a standardized graduated measure such as a syringe, also leading to inaccurate doses. Next, we will look at management of minor ailments. In this section we will cover 3 minor ailments. 1. Colic, which affects a large number of infants. 2. Pain and fever. And 3. Coughs and colds, which affect all children. as all parents or caregivers will find themselves needing to manage common ailments, and while medicines are available to treat many symptoms, often these common ailments require non-pharmacological management, and pharmaceutical care services to parents or caregivers require pharmacists to provide more advice and reassurance than medicines. We will now look at colic. Colic refers to paroxysmal abdominal pain associated with severe unrelenting crying, commonly occurring in children aged under 6 months. Colic is often the label that is given to describe the reason for crying in infants, but it must be noted that all babies cry, with crying intensity peaking at about 6 weeks and abating by 12 to 16 weeks. Colic itself has been defined as inconsolable crying for more than 3 hours a day and more than 3 days per week for a period longer than 3 weeks. It affects approximately 10 to 40% of infants. Crying is often worse in the late afternoon or evening. Wind is often blamed as the culprit, as many infants will draw up their legs, arch their back, redden their face, frown or grimace as well as pass wind. However, it has been suggested that these are in fact normal infant crying behaviors and not necessarily gastrointestinally related. Many parents or caregivers, however, feel that there may be a gastrointestinal cause to their infant's crying and hence turn to over-the-counter or prescription products for help. And now we will focus on medications. Medication that have been indicated for colic treatment have included infant drops containing belladonna alkaloids, atropine, hyoscine, and hyoscyamine, or other anticholinergic agents such as dicyclamine. These work on the basis of reducing gastrointestinal motility. However, current guidelines recommend avoiding use due to adverse effects. In some countries these medicines were available over the counter, whereas in other countries, they were restricted to physician prescription. Simethicone drops are also commonly used for colic on the basis that they will act as a surfactant to merge small wind bubbles together. Other agents sometimes used include homeopathic formulations containing bryonia, chamomilla, colocynthus, magnesium phosphate, or gripe water, in which ingredients vary according to manufacturers, but variously include dill seed oil, caraway oil, cinnamon bark oil, clove bud oil, cardamom oil, coriander oil, fennel oil, peppermint oil, Filipendula ulmaria, that is meadowsweet, extract. More recently, probiotics have been trialed for colic, and finally, sometimes proton pump inhibitors are prescribed. What is most important, however, is that there is conflicting evidence as to whether any of these treatments provide relief and whether they are necessary. We will now progress to medication errors or drug-related problems. Infant drops containing belladonna alkaloids or dicyclamine have been indicated for use in infant colic. However, use of these drops has resulted in anticholinergic toxicity. Symptoms include agitation, sedation, irritability, seizures, and coma in serious cases. In Australia, data indicate a number of calls to poisons information centres before these belladonna alkaloid products were discontinued, with 10-fold dosing errors of colic medicines in general being a common reason for calls to the centres. In a USA study, the most common reason for errors when dosing colic medicines was also found to be a misunderstanding of the instructions. Often parents administered full droppers of medicine instead of a discrete number of drops. Furthermore, caregivers admitted to administering these medicines more frequently than advised. We will now discuss caregiver management of colic. Parental support and reassurance are the key components of colic management, especially for first-time parents. Firstly, pharmacists should be ensuring there are no symptoms that would suggest something other than colic and hence require immediate referral. These could include lethargy, feeding refusal, fever, or a distended abdomen that could implicate serious underlying illness if associated with inconsolable crying. Other questioning should be about the infant's bowel habits, checking for diarrhea or constipation, and also checking if the infant has been vomiting. Again, these symptoms lend themselves to more sinister pathology, and referral would be appropriate. Furthermore, questioning around feeding and weight gain is also required. If the child has no other signs or symptoms of serious pathology and seems otherwise well, most commonly advice and reassurance is what is required. When it comes to selecting medicines, the following issues should be considered. The probiotic Lactobacillus reuteri has been shown to reduce colic symptoms in some trials. However, the latest evidence suggests it is only effective for colic treatment in breastfed infants. Simethicone, while widely available and commonly used, seems to be safe, however has not been shown to be effective in reviews. Herbal and homeopathic drops have limited evidence for their efficacy. Anticholinergic agents such as dicyclamine are contraindicated in infants less than 6 months due to adverse effects and should not be recommended. Proton pump inhibitors have also not been shown to be effective in reducing crying time. Therefore, in general, when providing pharmaceutical care to a colicky baby, as they are in the infant stage, the care is directed to the parent or caregiver only due to age. The pharmacist has a role in guiding caregivers in their treatment choices and making sure referral to the physician occurs when required. Trailing a change of infant formula and seeking advice about specialized formulas could be recommended in formula-fed babies, and assisting maintenance of breastfeeding in breastfed infants should also be encouraged. And now we will look at pain and fever. Pain is often formally defined as an unpleasant sensory and emotional experience, associated with or expressed in terms of actual or potential tissue damage. An alternative definition is, pain is whatever the experiencing person says it is, existing whenever the experiencing person says it does. Both of these definitions highlight that pain is more than just tissue damage triggering a response from the nervous system. Hence, its treatment involves more than just treating tissue injury. To further complicate the issue, children and especially infants are often unable to describe or express the pain they are suffering, making treatment even more complex. When assessing pain in children, it is important to ask questions regarding intensity, duration, description, the impact the pain is having on activities, and factors that may influence a child's perception of pain, which may include past history, or family or cultural aspects. Fever is a normal physiological response to infections and is recognized as a core body temperature of 38 degrees Celsius or greater. Depending on where the temperature is taken, rectal, oral, axillary, tympanic, fluctuations in thermometer readings will however be seen. It is recommended that for most children in the home setting that an axillary thermometer is used, as they are cheap to purchase and relatively easy to use. Fever is a common occurrence, especially in children, and nearly all caregivers will find themselves needing to manage fever for their children at some stage. While there is evidence that the analgesic agents will decrease temperatures by a modest amount, it is important to realize that fever itself does not require treatment, and that the benefit of these analgesic agents is therefore on the pain associated with fever, and even these benefits are not conclusive. However, fever in children 3 months or younger should be immediately referred for further investigation. We will now switch gears to medications. Paracetamol and ibuprofen both are effective in relieving pain with or without fever in children, and they both have few side effects when used correctly for short-term use. The recommended dose of paracetamol is 15 mg per kilogram every 4 to 6 h with a maximum of 4 doses in 24 hours, dosed at 60 mg per kilogram, and this should be used for up to 48 hours only at this maximum dose in the community setting. In the hospital setting, slightly higher doses may be seen, but these are reserved for severe pain, usually in an intensive care setting. The recommended dose of ibuprofen is 5 to 10 mg per kilogram every 6 to 8 hours, hence a maximum of 40 mg per kilogram per day. Although many of these products are available for administration via the oral, rectal, and intravenous route, the oral route is preferred. In fact, the rectal route has highly unpredictable absorption and is therefore not a recommended administration route if it can be avoided. We will now discuss medication errors or drug-related problems. Paracetamol and ibuprofen use and misuse in children is ubiquitous. They are the most commonly used over-the-counter medicines in children and the most common medicines kept at home. The published literature demonstrates that most misuse can occur due to accidental ingestion, inappropriate administration, false parental or caregiver beliefs of efficacy and safety, and inability to use as directed. Moreover, most parents remain unaware of the side effects of over-the-counter medicines, and there is evidence suggesting that medicines are often used for inappropriate indications, including the use of paracetamol to sedate children. In overdose, both ibuprofen and paracetamol are dangerous, so correct dosing is paramount. There are many dosages of liquid paracetamol and liquid ibuprofen available. With these formulations, there are different marketing strategies guiding the various strengths to be used. For example, the strongest paracetamol liquid is marketed for use in babies, so that very small doses are to be given. In contrast, the weakest liquids for both ibuprofen and paracetamol are often marketed for 1 to 5-year-olds. In addition, in many countries, there are age and weight dosing instructions on the packaging, with often the dose indicated as a range such as 6 to 8 milliliters. Due to all these factors, it is easy for parents to make errors when calculating or measuring a correct dose of medicine for their children. Furthermore, unfortunately, research continues to demonstrate that caregivers inappropriately manage fever and adopt practices not stipulated in current guidelines. Studies have reported that caregivers respond to fever with significant concern, perceiving it as harmful with detrimental bodily effects such as neurological damage, organ damage, and death, which are not true. Some recent research at the University of Sydney revealed that negative attitudes toward fever, aiming to reduce the temperature, misinformed views of medications, and misunderstanding of package labeling were the main factors driving inappropriate behavior of caregivers when treating fever. This research also revealed that fever management was only appropriate in 15% of caregivers interviewed. These data suggest that pharmacists need to spend time counseling caregivers on appropriate pain and fever management, and if a medicine is to be used, explaining how and when to dose as suggested above, is important. Next, we will focus on caregiver management of pain or fever. For pain that involves inflammation like a sprained ankle, for example, ibuprofen may be more suitable than paracetamol in this case, due to its anti-inflammatory effects. For other simple pain, a choice of one or the other agent should usually be made, and often paracetamol is first choice for many due to its long safety history when given correctly. For moderate to severe pain, sometimes a combination of products can be recommended. However, commonly in children with mild pain or fever, one agent alone will be enough. There are also non-pharmacological things that can be done in conjunction with analgesia to comfort a child in pain. Some of these include having a parent comfort the child, allowing the child to ask questions if they are able, or advising the child to focus on deep and steady breathing. Distraction methods can also be very helpful, so the use of books, video games, or television are commonly used distractions. Play is an excellent distraction also, but it should be noted that just because a child is able to play, it does not mean the pain has gone away. Positive affirmation like, "You are doing great," are also recommended, as well as comforting the child through plenty of cuddles and attention. Ice packs or heat treatments are also sometimes used. For fever, removing one layer of clothing and keeping the child hydrated are also very important. As pharmacists, it is important that we guide parents to the weight-based dose instructions, and we give caregivers an exact dose to measure based on the child's weight, unless the child is obese. We should give an oral syringe to assist with dose measurement and show caregivers how to use this syringe. Research has shown that only about 1/3 of parents will get the dose right for their child. Hence, this advice is extremely important. In the community setting, it is best to advise a caregiver to choose only one medicine and stick to it. For example, if paracetamol is the medicine chosen, then this should be the only medication used for the condition. While a combination of both paracetamol and ibuprofen may be required for some more severe pain in children, this is best only used on the advice of a doctor, as mistakes with one product are very common. Hence, mistakes with two products would seem to be much more likely if combinations are used. While we see the practice of using two medications commonly, particularly for fever, there is no need to alternate or dose two medicines together, as the fever is normal biological response to infection that does not need treatment. Instead, as pharmacists, we should be encouraging practical non-pharmacological management such as removal of clothing and increased fluids and rest. When thinking about the pharmaceutical care issues involved in pain and fever management in a pharmacy setting, if the child is verbal, they should be involved in the decisions around their treatment and included in the choice to medicate. As errors in the use of analgesics are so common, the pharmaceutical care dosing principles should be passed on to parents, and in turn their children as early as possible, to perhaps break this cycle of poor medication administration. Next, we will look at cough or cold. The common cold is most often a self-limiting virus which can affect people of all ages. The average child will have 6 to 8 colds per year, with those attending childcare having on average 10 colds per year. Symptoms generally include nasal blockage or rhinorrhea, sneezing, coughing, headache, and fever. Medicines available over the counter for colds and flus only provide symptomatic relief, and no study has proven the efficacy of cough and cold medicines in improving the rate of recovery in young children. Generally, children will eventually improve on their own in 10 to 14 days without any treatment. We will now focus on medications, medication errors, and drug-related problems. Many over-the-counter cough and cold products contain multiple substances, including a decongestant, antitussives, antihistamine, and sometimes analgesics or antipyretics. When taken in high doses, decongestants such as pseudoephedrine result in central nervous system stimulation, hypertension, and tachycardia. Serious complications after ingestion include hypertension, tachycardia, bradycardia, seizures, stroke, and cerebral hemorrhage. These concerns have resulted in the release of safety advisories from various regulatory bodies in developed countries, discouraging the use of these medications in young children in recent years. For blocked noses in adults, we would use decongestants. Oral decongestants may include phenylephrine and pseudoephedrine. In children, There is no evidence that these products improve symptoms, and unfortunately, there are case reports of adverse drug events. For this reason, these products are not to be sold over the counter for children under 2 and are not recommended for use in children under 12 due to their limited efficacy data in many developed countries. Topical decongestants, such as oxymetazoline and xylometazoline, are less well studied, but with the limited studies available, there is still no evidence to recommend these products for children. Other products that are common in cough and cold preparations to treat nasal symptoms are antihistamines. The evidence regarding sedating antihistamines contained in cold and flu products for children is clear that these have no benefit in treating colds, and are associated with an increased risk of adverse effects and even sudden infant death. Preparations containing sedating antihistamines cannot be recommended for children under 2 years of age. Vapor rubs and essential oils have been associated with case reports of seizure, although most of these follow accidental ingestion rather than topical application. The evidence, however, for the effectiveness of these rubs is also lacking, and only the baby balsam formulas can be used for children under 2. For dry coughs, the usual recommendation in an adult might consist of a cough suppressant. In children, however, we also have no evidence to support the use of such products. In fact, a recent review found that cough mixtures were no more effective than placebo for both children and adults. Cough suppressants should not be recommended for children in general, and cannot be sold legally without a prescription for children under 2. The research surrounding cough mixtures for chesty coughs is also unclear, and while there may be less safety concerns with some of these products, e.g., bromhexine, we still do not have firm outcomes on their efficacy in children. Next we will discuss caregiver management of coughs and colds. Nasal saline drops have proved to be safe for blocked and runny noses and therefore can be used. It is important to encourage children to clean out the nasal passages through blowing their nose, to avoid secondary sinus infections. Saline drops can certainly help with this. Honey can help soothe coughs. However, this should only be in children over 12 months of age, as in children less than 1 year of age honey has been associated with infantile botulism. Common sense prevails, and of course children should be advised to intake more fluids, that is water, and rest. Paracetamol or ibuprofen can be given if the child is very miserable due to pain, fever, but if they are eating, drinking, and still happy, no doses are required. The use of a steam vaporizer or humidifier could be used, although if this is recommended, a very firm warning for parents to put these out of reach of children is warranted, as they have been associated with steam burns if they are in a child's reach. It is important to provide patients information regarding their children's colds and give them realistic expectations. They should be advised that there is no cure for their child's cold, and practical things such as rest, increased fluid intake, and adequate nutrition are the mainstay of treatment. Although there are many liquid medicated cough and cold products, usually containing a combination of decongestant and a drowsy antihistamine or an expectorant or a cough suppressant, available to treat children, most of them are not suitable for children under 6 years of age. With this in mind, non-drug treatments should always be your first choice when treating children. Pharmacists should recommend caregivers to see a physician when there is 1. Persistent symptoms for more than a week, especially persistent nocturnal cough. 2. Fever, 38 degrees Celsius or higher for more than 3 days or in a child under 3 months. 3. Suspected dehydration. 4. Blood in sputum. 5. Cold causing exacerbation of asthma. 6. Tonsillar exudate. 7. or sudden worsening of a child's symptoms that are worrying to the caregiver. As for pain and fever, children that are verbal should be involved in the decision-making around their treatment of the common cold, again in order to empower the next generations to break the cycles of non-evidence-based treatments. We must try to educate the public, both adults and children, that the common cold still has no magic medicine available to cure it. We will now look at pharmaceutical care in chronic conditions or complex situations. When it comes to managing chronic conditions in children, it could be perceived as even more important that children are involved in their pharmaceutical care as soon as possible, and that as they grow, more and more autonomy is given to them. A snapshot of literature illustrated that delegation of responsibility is not an easy decision for parents to make. For chronically ill children, premature transfer of responsibility could lead to poor health outcomes due to children's inability to cope with the increased responsibility. On the other hand, delayed transfer and miscarried helping can interfere with the development of children's autonomy and promote excessive reliance on others. Moreover, studies have demonstrated that deterioration in health outcomes is usually observable during adolescence, the time when parents allocate more self-management responsibility for chronic illness to their offspring, despite the rise in children's knowledge and skills. These findings call for the establishment of collaboration between pharmacists, parents, and children so that a smooth transition that upholds the quality use of medicines can be achieved. We will now progress to eczema. Atopic dermatitis, or eczema, is a common inflammatory skin condition which is associated with other atopies such as allergic rhinitis and asthma. Most children who develop atopic dermatitis will do so before the age of 2 years, and it is estimated that around 20% of infants under 2 years will experience it. Indeed, the prevalence of atopic dermatitis is growing rapidly. While atopic dermatitis is considered a chronic condition, and this should be made clear to the family, most children will experience flare-ups interspersed with periods of time when the skin is not inflamed. The goal of treatment is to completely clear the skin between flare-ups and to swiftly reduce inflammation when the skin flares up. In order to minimize the chance of flare-ups, the following lifestyle measures can be undertaken to improve the barrier nature of the skin's defense. 1. Using soap-free washes where possible. 2. Having shorter showers and running more tepid than hot water. 3. Avoiding known irritants like chlorine, grass, and sand. 4. Using simple emollients, particularly when the skin begins to look dry and flaky. 5. When the skin is inflamed, the first-line treatment is topical corticosteroids. We will now look at using topical corticosteroids, abbreviated as TCs, effectively. Topical corticosteroids, that is TCs, should be used early, liberally, once daily to all areas of inflammation including broken skin and even up to the borders of wounds. They are best applied when the skin is damp, such as after a shower or bath. They should be used for at least 1 to 2 weeks and stopped only when the skin is looking not inflamed and restarted again if needed. Some patients will require long-term treatment. For longer treatment periods, intermittent therapy such as every other day, weekend-only application or a resting period of 1 to 2 weeks between cycles may be an option. In the past, many medical practitioners and pharmacists have been very cautious in their recommendations about using topical corticosteroids. Pediatric dermatologists now commonly voice their frustration that GPs and pharmacists are too conservative and provide patients with outdated risk messages such as, use topical corticosteroids sparingly, apply them thinly, or avoid them altogether. For example, even in 2016, a high proportion of Australian caregivers reported that they had been told these risk messages, often, or always, by both GPs and community pharmacists. These messages are perpetuated by members of family and friends and appear in online searches about topical corticosteroids. Of course, the main reason for such conservatism is the concern that topical corticosteroids might cause side effects such as skin thinning, that is atrophy. However, the good news is that an Australian observational study showed that even when potent steroids had been used for children for around 1 year, there was no evidence of atrophy. Indeed, current consensus is that skin thinning, hypopigmentation, hypertrichosis, osteoporosis, purpura, or telangiectasia do not occur in pediatric dermatology when used appropriately as per guidelines. While practitioners should be concerned to avoid atrophy through overuse, it is far more likely to occur when highly potent topical corticosteroids are used chronically, without rest, for a long time. Care should also be used when using topical corticosteroids on the face because perioral dermatitis can be aggravated by topical corticosteroids. How much TCs to use? The appropriate potency and strength to select is available from consensus guidelines. The fingertip unit, abbreviated as FTU, was developed in 1991 and is a useful tool to think about the amount to use. A fingertip unit is defined as the amount of steroid preparation squeezed from a tube that will fit along an adult's index finger to the first crease. How much to use depends on the site. There are 3 bases which can be used to deliver topical corticosteroids to the skin: lotions, creams, and ointments. Lotions, which contain a high proportion of water, can give a cooling effect, but also they can sting and are best avoided. Creams contain water with an oil component. Creams too can cause stinging when the skin is inflamed and should be avoided during flare-up. Creams may be useful if the skin is not very inflamed. Ointments are the most appropriate option when the skin is inflamed and/or dry. They cause less irritation and deliver topical corticosteroids better. Occasionally, caregivers do not like ointments as they feel sticky and messy, but they are quite effective in improving hydration. While itching, pruritus, is a hallmark of eczema, there is really no role for antihistamines. Occasionally, topical corticosteroids are not effective, and in these cases, referral to a pediatric dermatologist is warranted, because there is a high prevalence of Staphylococcus aureus, which may require specific antibiotic therapy and referral to a medical practitioner. There is increasing interest in the use of bleach baths and/or nasal mepiosin ointment to reduce staphylococcal load in difficult-to-treat atopic dermatitis. And now we will discuss childhood asthma. Past research has identified many issues that have been poorly dealt with respect to childhood asthma management, including lack of parental knowledge about asthma and asthma medications, lack of information provided to parents, parental beliefs and fears, parental behavioral problems, the high costs of medications and devices, the child's self-image, the need for more child responsibility, physician non-adherence to prescribing guidelines, off-label prescribing, poor understanding of teachers, lack of access to educational resources, and specific medications. With asthma being the most prevalent chronic disease of childhood, with approximately 14% of children worldwide experiencing symptoms of asthma, pharmacists need to be working hard to ensure that asthma management education is being provided to the child and parents, as well as to the supporting community that has responsibility for children with asthma. The following case study highlights that even in a simple, straightforward case of dispensing 2 medications for a child, There is a plethora of information and skills that needs to be divulged to a large range of people. The following case illustrates the specific aspects of the treatment of asthma in children. Next we will discuss an asthma case scenario. Mrs. Dunder and her 6-year-old daughter Mishka enter your pharmacy with a new prescription for fluticasone and salbutamol metered dose inhalers. For the past few months over the winter, Mishka has had several colds that she hasn't been able to fully get rid of, and she has been waking at night coughing. A few times this term at school, when she was running in the playground, she got so out of breath. The school teachers had to administer salbutamol via a spacer to relieve her breathlessness. After investigation, Mishka has been diagnosed with asthma and active regular preventer treatment has been deemed necessary. In this particular case, there is a huge amount of pharmaceutical care that needs to be provided by the pharmacist, and the information must be given both to Mishka and to her parents, and some information may also need to be disseminated to the other support community involved in Mishka's care, including teachers. Some of the types of information and services that need to be provided include the following. 1. Explanation of what asthma is and why it needs treatment. 2. Explanation of the different puffers, that is, reliever and preventer. 3. Demonstration of inhaler use with a spacer. 4. Checking technique of individual and caregivers. 5. Explanation of peak flow monitoring. 6. Explanation and demonstration of what to do during an asthma exacerbation. 7. Development of an asthma action plan and how to monitor for signs of worsening control. 8. Discussion on adherence to treatment. 9. Discussion of environmental control and avoidance strategies. And 10. Discussion regarding side effects and how to avoid them. These particular services could take up to half an hour and may need to be repeated each time a new prescription is dispensed, as there is so much for one to try to take in and remember. Of course, accompanying this information with written materials is also required. Also, placebo devices and demonstration spaces will need to be used. While the principles for asthma management are no different to those described in Chapter 27, the extra steps in educating children and their surrounding community are also really important. Studies have highlighted that hands-on skills training in how to use a reliever device and spacer provided by pharmacists can vastly improve the way an acute exacerbation is handled. Furthermore, education provided by pharmacists to children with asthma and their parents have shown improvements in knowledge, quality of life, and inhaler technique. Thank you.